this video today, we're going to continue talking about the heart, and we've already gone through heart failure. Now we're going to cover ischemic heart disease, hypertensive heart disease, and congenital heart disease. And we'll start out with ischemic heart disease. Ischemic heart disease is basically what its name is all about. You have ischemia, and you don't have enough perfusion of blood going to the myocardial cells. So we can't meet that demand, and that's usually due to coronary artery disease. Now, coronary artery disease can be either a narrowing of the coronary arteries, so there's not enough blood flowing, or blockage of the coronary arteries like atherosclerosis. So 4 signs of ischemic heart disease would be angina pectoris, acute myocardial infarction, chronic ischemic heart disease, and sudden cardiac death. And we're going to go over these. So let's take a second and watch a video that I think you'll find very interesting.
Atherosclerosis occurs as a result of atherogenesis, or accumulation of fatty substances, cholesterol, cellular waste products, calcium, and other substances, which may build up in the inner lining of the coronary artery, resulting in plaque formation. Atherosclerosis produces an area in the vessel wall which may act as a focus for atherosclerotic events. Cores with a high lipid content tend to rupture, activating clot formation or thrombosis. Although blood flow may not be obstructed at rest or on exercise by a plain plaque, plaque rupture and thrombosis can block the artery at sites where stenosis has occurred.
All right, so this is just a picture going back over what you just heard in that video. So what happens again is that something causes tears or destruction somehow of the arterial wall, and we've talked about this a little bit in the blood vessel video, and those tears or that destruction could be due to a number of things. One is continuous high blood pressure. Another would be causing the blood vessels to vasoconstrict. And that vasoconstriction, of course, again, causes high blood pressure, but this is due to things like too much stress and smoking and too much alcohol in the diet. Another thing we know that can cause destruction of the blood vessel lining is high levels of carbohydrates in the diet. And so you have things that stick. And then eventually what happens is you develop a thrombus, and now you have complete clogging of those blood vessels. Now, angina pectoris is due to this ischemic heart disease, and what happens is the person is going to experience chest pains. And it can be caused by transient ischemia, and you may only get it for a little while and then it's reversible, or it could be more long-term. So there's a couple different types of angina that people can experience. One is called typical or stable angina, and the person is going to have more pain upon exertion. So let's say I'm exercising, and because I have a slight blockage, you might say, in the coronary arteries, I'm still getting some blood flow, and it's okay for when I'm resting. But when I'm exercising now, I need more blood to the heart, and I have this plaque. I can't get that extra blood. I'm going to experience pain. So this is a fixed narrowing of the coronary arteries with a stable plaque. Whereas you could also have what's called unstable or pre-infarction angina. And this is where the person is experiencing more and more pain, but they don't necessarily have to have any exertion at all. And this is an unstable plaque, and so you may have a disruption and a thrombosis, and you have complete occlusion of those coronary arteries eventually, which, by the way, will lead to myocardial infarction. So myocardial infarction, or what we would consider more like heart attack, is necrosis of heart muscle, and this is caused by the ischemia. So we have about 1.5 million people who have myocardial infarctions each year in the United States, and most of this is due to acute coronary artery thrombosis. So you have this sudden plaque disruption because the wall has exploded, you have coagulation, and the coagulation cascade is all of the different steps that have to happen in order for a blood clot to form. And then you have this thrombus, and it totally occludes the lumen of your coronary artery. And so what happens is now I have no blood flow because of this occlusion, and probably I've had very little blood flow to my coronary muscles for a long time now. And so it's going to cause cellular death. And these are irreversible injuries. Once those cardiac muscle cells die, they're not coming back. So what's very important is trying to get blood to flow to the cardiac muscles as quickly as possible. And so this is what all of those surgeries are about, trying to go in and open up those arteries so that we can save as many muscle cells as possible.
Atherosclerosis is a life-threatening disease that may have begun to develop during childhood. This condition is a process in which deposits of fatty material, called plaque, build up inside the walls of arteries, reducing or completely blocking blood flow. Although the exact causes of atherosclerosis are not clear, many scientists think it begins with damage to the inner wall of an artery, called the endothelium. Substances traveling in the blood, such as cholesterol, fats, and cellular waste products, accumulate inside the damaged area of the arterial wall. Chemical reactions occurring within the buildup of material cause cholesterol molecules to oxidize. This initiates an inflammatory response in which the endothelial cells at the damaged site release chemicals that signal a call for help. In response, monocytes from the bloodstream travel to the damaged site. Stimulation from oxidized cholesterol converts the monocytes into macrophages. The macrophages eat and digest the cholesterol molecules. As a result of this process, the macrophages change into foam cells, which accumulate to form plaque. As the plaque increases in size, the arterial wall thickens and hardens. At the same time, smooth muscle cells within the arterial wall begin to multiply. Most of the smooth muscle cells move to the surface of the plaque. These cells contribute to the formation of a firm, fibrous cap covering the plaque. Eventually, the passageway through the artery narrows enough to reduce blood flow and the amount of oxygen received by the organs it supplies. Over time, the cap may erode and break open, releasing plaque into the bloodstream. The plaque can flow downstream and contribute to the formation of a blood clot, which can stop blood flow. As a result, limited blood supply is available to the area surrounding the partially blocked artery, degrading and potentially killing the neighboring tissue.
Okay, so let's talk about some more things about myocardial infarction. So a couple of things you saw in the videos, looked at coronary artery disease, and then also looked at, basically you saw some of the symptoms that people have from myocardial infarction. So when a person has a heart attack, what is happening is their cardiomyocytes, their muscle cells, are not being fed. So there's insufficient perfusion, that ischemic heart disease is going on. And while the heart attack is occurring, these muscle cells are dying off. And as the muscle cells die off, you see muscle cells literally exploding. And depending on how bad this clogging is and how many muscle cells die, many people who have heart attacks will die within the first 20 minutes. And this is because they have such ischemia problems and so many cardiomyocytes exploding. So it's very important with heart attack for people to get in and have something done to increase perfusion to the heart. So as far as symptoms are concerned, you hear things like, oh, well, the person has left arm pain, or they have crushing chest pains, and of course those things do occur kind of sort of for the people who are lucky, because we do think about that crushing chest pain or that left arm pain and go, oh my gosh, we're having a heart attack. But that's not actually what the majority of people are going to feel. When they have a heart attack, the majority of people are going to have indigestion. And who equates indigestion with having a heart attack? And so you may have a person who has this mild indigestion for months and months and months, and they don't even know that they're having these mild heart attacks. And eventually, all those mild heart attacks are going to build up to something major, because you have little bits of muscle cells dying, and those little bits of muscle cells start to add up, and now you have a lot of muscle cells that are dead, and this is obviously a huge issue. And so what's happening is there are various different nerves that are going to the brain that are also associated with the heart. So these nerves are going to originate in different parts of the body, though, and not originate in the heart. So for instance, you have some nerves that originate in the left arm, and then the nerves from the heart also kind of go together with those nerves from the left arm to the brain. So when the heart is having pain, the brain may misinterpret this as the left arm is having pain. Other nerves that originate in, let's say, the stomach region are going to then hook up with the nerves that come from the heart and go to the brain as well. And so people are going to think, oh, wow, I'm just having some stomach issues, I'm having some indigestion, because the brain got it wrong. And really what the brain should have been saying is, hey, you're having crushing chest pains and you're having a heart attack. But this indigestion isn't normal indigestion. The person feels typically a little bit sweaty, kind of cold sweats going on along with the indigestion. But you'll see that a lot of people who have had this long-term indigestion, they're taking their Tums and their Rolaids and they're trying to get over it, and they just can't. And so we say, when you have long-term indigestion like this, you need to go and have it checked out to see if this happens to be the heart. So because these cardiomyocytes are dying, they're exploding, you see different changes that happen to the heart muscle. And so the heart muscle takes on some different coloration in order to show that things have happened and aren't good. So you have this mottling, which is kind of these little white dots throughout the heart muscle. And when you look at it under a microscope, you can see coagulation necrosis happening because of the neutrophils that are coming in. Eventually, after several days after having the heart attack, it starts to look yellow in the area where the muscle has died. And that's because the neutrophils have died off and macrophages are coming in and eating the dead tissue. You get some granulation after a few weeks, and then you even get white collagen scar tissue building up in there. So right here you see a little bit of the necrosis that's starting to occur. It's a little bit darker in color. But here you see the yellow buildup that has occurred, and then here is an older heart attack, here older where it's white with the collagen. So this would be a little bit newer heart attack, but you see how much muscle has died and in various different places. So what's happened to this person is they've had multiple heart attacks over time and unfortunately didn't take care of it. And then notice also how you have hypertrophy as well, and the ventricles are very, very small, and so you're having a lot of ischemia going on here. This is also showing you the difference on a microscopic level of what the muscle cells are looking like. This is 1 day after a myocardial infarction, and it looks fairly normal. This is 3 days later, and you can see all of the neutrophils moving into the area. And right here, these are all macrophage that have moved into the area. And of course, that's because all of this muscle cell is completely disrupted and dead. This is also why after a person has a heart attack, you measure troponin levels, because troponin is being released from the cardiac muscles, and the higher the troponin levels, the indication is that more cardiac muscle cells have exploded and there's more death of those cells going on. So again, severe crushing chest pains, radiation down the left arm, these are clinical features. They're not relieved by nitroglycerin or rest. And nitroglycerin, what it's doing is it's going to vasodilate our blood vessels in order for that ischemia to the heart to decrease. Like I said, the person may have the sweating, but it's more of a cold sweat, nausea, dyspnea, difficulty breathing. Sometimes no symptoms at all. I had a friend who had multiple minor heart attacks, which led to a major heart attack. And one day he was just walking out to his car to go to work, put the key in his car to open the door, and dropped dead of a heart attack. And the only symptom that he had was that he had continuous sore throats. And he kept going into the doctors because his throat was so sore, and he's trying to figure out what the heck is going on. And the doctor kept swabbing his throat, looking down his throat, and basically said, dude, I have no clue. Which is really sad because his brother had passed away from a major heart attack not too many months before he did, and then his dad had also died of a major heart attack, and it was the same doctor that all three of them had, so it wasn't like the doctor didn't know that heart problems ran in the family. And my friend was only 32 when he passed away, and the reason that the sore throats were such a big deal is because he was an opera singer. And so he couldn't sing. He said the sore throats were so bad that he wasn't able to sing. And the doctor never put 2 and 2 together. And you think, okay, well, how in the world would the doctor even do that? But again, the nerves that originate in the throat also hook up with the nerves to the heart, to the brain. So, this is what we really call referred pain. And you have to kind of really try to think about referred pain when certain things run in families. Like, for instance, okay, this is very weird, but you have a female who comes into your emergency room and she's complaining of really bad pain in her right knee. And when you ask her, did you have any type of fall? Did anything happen? She goes, no, just all of a sudden my right knee starts hurting. So you take x-rays, you palpate, maybe you even get an MRI because the knee hurts so bad. Do you think about the fact that that right knee pain could indicate cancer of the ovaries? Not usually, but referred pain would say that the nerves that originate in the knee also hook up with the nerves from the ovaries. Those guys go to the brain together, and the brain can confuse where does this pain originate from. Is it the knee? Is it the ovaries? I don't know, and the brain picks one. Well, the knee is the most obvious place to pick, and now our patient dies from cancer of the ovaries because we didn't think about referred pain. It's a big issue. So again, troponin levels are going to increase within 2 to 4 hours. They can remain elevated for weeks. You also have what is called creatinine kinase and myoglobin. Now, creatinine kinase is an enzyme that is also released when our cells explode, and those levels can be measured along with myoglobin. Now, myoglobin is like hemoglobin, but myoglobin is found only in muscle cells, and that's skeletal muscle, smooth muscle, cardiac muscle. And myoglobin, what it does is it, being like hemoglobin, has an attraction or affinity to oxygen. It actually has a higher affinity to oxygen than even hemoglobin. So when blood is flowing past the muscle cell, the myoglobin is able to kind of suck that oxygen out of the blood and into the muscle cell and helps keep that muscle cell alive. So now, again, when our cardiomyocyte explodes, myoglobin is released, and within the first few hours, we can test this creatinine kinase or myoglobin levels to see what's going on. So some of the complications with myocardial infarction would be contractile dysfunction, which means that now, depending on how many muscle cells have exploded, how well does the heart contract? So if we have multiple small heart attacks, or even if we have one major heart attack, we may decrease muscle contraction so much that it's inconsistent with life and our patient isn't going to survive. Also, remember, the heart has an electrical system. The heart is what we call a syncytium, which means that the heart has to contract all of its muscles in a very particular pattern. So the atrial cells are contracting the heart in a downward fashion, while the ventricular cells are contracting the heart in an upward fashion. And all of these action potentials have to run in between muscle cells in order for that pattern to occur. But if I have exploded muscle cells, I don't have the ability for these action potentials to move from one muscle cell to the next, to the next, to the next. It's kind of like, think about dominoes. If I set up all these dominoes and they're supposed to fall in this massive pattern, and I take a handful of dominoes out of, let's say, the middle of the structure that I've built, once I start the pattern, it's not going to be able to continue because I have this gap in dominoes, and it's the same thing with our muscle cells. And so that can also decrease contractile dysfunction. It can also create arrhythmias. And then we've talked about ruptured muscle, and then we have chronic progressive heart failure. As these muscle cells become weaker, the heart continues to fail. It can't pump what it's supposed to pump. And the prognosis really depends on how many muscle cells do we have, how well is our heart pumping, how much perfusion do we have to our remaining muscle cells. Overall, we have a 30% mortality rate 1 year after a heart attack, 3 to 4% mortality per year thereafter. So it's really, really important to get your patient exercising and eating well and making sure that they keep what they have of their heart, if at all possible, as healthy as possible. So different things can rupture in the heart, and that includes the papillary muscles. So that's what you're looking at here. Here's a papillary muscle, chordae tendineae, and this papillary muscle has ruptured. Now, the thing about having a ruptured papillary muscle is now you can't keep the valves closed like you're supposed to, which can lead to heart murmurs. All right, so our next part is going to be talking about hypertensive heart disease. And hypertensive heart disease can affect the left or the right ventricle, and if it affects the right ventricle, it can be because of cor pulmonale. So you have right ventricular enlargement due to pulmonary hypertension, and this is caused by primary lung disorder. So let's talk about this just for a little bit. So now imagine, let's talk about hypertension in the lungs, this cor pulmonale first, and then we'll go into left ventricular problems. And so imagine you have the right ventricle and it's trying to pump blood into the lungs. And as the right ventricle is trying to do its best to pump blood into the lungs, it's having difficulty because you have hypertension in those blood vessels. So now the right ventricle is having to pump even harder and to get that blood flowing through the lungs into the left side of the heart than it did before. So if it's having to work harder, what's going to happen is the muscle of the right ventricle is going to hypertrophy. So imagine you're lifting weights. So you're now working harder than you have been before. And as you lift those weights, obviously what's going to happen is you're going to have hypertrophy of your muscles so that you can do this job better. The same thing's going to happen with the left ventricle as well. So as the blood is being pumped from the left ventricle into the systemic circulation, if we have hypertension in the systemic circulation, the left ventricle is going to have to be working harder also. And that increase is going to cause left ventricular hypertrophy also. So you have myocyte hypertrophy that's occurring. And the reason for heart failure in hypertension is really kind of poorly understood, because here's the weird thing. You would think that the heart would just become stronger and have the ability to continue to pump that blood even though there's hypertension in the system. The issue becomes the heart is too thick first and then eventually wears out. So you're looking at this one here on the left side. This is left ventricular hypertrophy. And then here you have right ventricular hypertrophy. So you have the muscle getting larger, even in the septum, than it's supposed to be, which one of the outcomes for that is that the ventricle itself is actually much smaller. So you can't get as much blood in that ventricle as you used to. So even though the heart is working harder at getting the blood into the circulation, you can't put as much blood into the circulation because the ventricle is so small, it won't fill with blood. And then after a while, the ventricle keeps growing and growing and growing in size as far as hypertrophy is concerned, and then it just stops. It won't hypertrophy anymore. Instead, you start to see enlargement of the heart. And so the heart starts to get bigger, and as it does, the muscle actually starts to thin out. And that thinning of the muscle can lead to heart failure. So in order to help individuals out with this, we have several different types of drugs that can be used, and one is called a chronotropic type of drug, and this alters heart rate. So for instance, atropine, beta blockers, digoxin fall into this category, and atropine is a parasympathetic antagonist. So you have agonist and antagonist. So an agonist is something that binds to a receptor and it increases what that response would normally be. An antagonist binds to the receptor and decreases the response. So atropine, being a parasympathetic antagonist, decreases the response of the parasympathetic nervous system, which means the parasympathetic nervous system is going to lower heart rate, but atropine will actually allow heart rate to be faster. Beta blockers compete with beta receptors, and those beta receptors bind to epinephrine and norepinephrine, which we know speeds up heart rate. So beta blockers helps to slow heart rate. So this would be like atenolol, propranolol. These are some examples of beta blockers. Digoxin strengthens heart muscle contraction, and it also helps to slow heart rate. Then you have ionotropic medications, and they alter myocardial contractility. So this is very helpful, especially after that hypertrophy response. When the heart is starting to thin out, you might need to get the heart muscle either contracting harder, or sometimes you need the heart muscle to contract less. So digitalis is a positive ionotropic drug. It slows heart rates, and we use this usually with atrial fibrillation, but a slow heart rate allows for greater cardiac contractility. Diuretics, we have two major types. One is a loop and one is a thiazide diuretic. These are affecting the kidneys. And a loop diuretic is going to reduce sodium reabsorption. So if we are excreting sodium out of the body, wherever sodium goes, water follows. A thiazide increases sodium loss. So that's going to also increase water loss. And now there's also some diuretics that are a combination, loop and thiazide diuretics. ACE inhibitors, if you remember, ACE is the enzyme that converts angiotensin 1 to angiotensin 2, and angiotensin 2 helps to cause vasoconstriction and also increase aldosterone release, which is going to increase sodium reabsorption. So we decrease vasoconstriction, we decrease sodium reabsorption, which also lowers blood pressure and allows for water loss. And then nitrates induce nitric oxide release, and this is for vasodilation. Okay, so that nitroglycerin type of thing falls into this category.